Now today our discussion is about type 3 hypersensitivity reaction. Type 3 hypersensitivity reactions. Now, to understand the type 3 hypersensitivity reaction, first of all you must know the basic fundamental that this is a disease, it's immune mediated tissue damaging condition. It is immune mediated tissue damaging condition due to deposition of immune complexes, formation and deposition of immune complexes which lead to inflammatory reactions. What are the things? Listen, what is there? The immune complex formation, immune complex formation, right? And these immune complexes lead to inflammatory lesions. They lead to inflammation. Is that right? And in this condition, the antigen is not fixed to any particular tissue. Antigen is free. Or wherever antigen antibody reaction occur, antigen is not part of that tissue. Antigen is free, antibody is also free. Free antigen antibody make the complexes which may get deposited in different parts of the body. Or sometimes antigen may go and deposit in some tissue first and antibody may follow. For example, in post-streptococcal glomerulonephritis, streptococcal antigens get deposited in the glomerular basement membrane and then antibody may follow. Or in the same condition, some of the streptococcal antigen and anti-streptococcal antibodies make immune complexes in circulatory system and then those immune complexes get deposited in glomeruli. And there at glomerular basement membrane, inflammatory reaction is activated. So the basic concept is that antigen in this case may be endogenous or exogenous, but it is usually free. For example, endogenous antigen may be, antigens in these cases may be exogenous or endogenous. Exogenous antigens may be bacterial antigens or maybe fungal antigens, right? And maybe viral antigens, right? For example, streptococcal antigen in case of post-streptococcal glomerulonephritis. Then fungal antigens in case of farmer's lung, which is localized type 3 hypersensitivity reaction. Viral antigens like hepatitis B antigens are involved in polyarthritis nodosa. Or antigens may be endogenous. For example, in SLE, right, you find DNA, right? DNA or nucleoprotein may act as antigens against which antibody reaction is there. So antigens may be endogenous or may be exogenous, and these are free antigen. They are not intrinsic to the tissue to which reaction is occurring. These antigens and antibodies are, antigens react with the antibodies, and antibodies may be IgG or they may be IgM. And then this antigen plus antibody which is making an immune complex, this is immune complex, right? This will through complement activation plus through inflammatory cells like neutrophils, it will lead to severe inflammatory reaction. Now, sensitivity reactions, type 3 hypersensitivity reactions are classified as generalized reactions, and they may be localized reaction. Generalized reactions are also called serum sickness type reactions. The serum sickness like reactions, right? And localized reactions are also called Arthus reaction. Now, First, I will go into detail of generalized or systemic reactions. Type 3 hypersensitivity reaction or immune mediated tissue inflammatory reactions, immune complex mediated inflammatory reactions in multiple systems or generalized in the body. First, I will discuss into detail, and then I will talk about localized reaction. When we talk about generalized reaction, we say it is serum sickness like reactions, right? So first of all, we'll talk about what is the concept of serum sickness, right? Because serum sickness type reactions were occurring in past very frequently, not now that frequently. In past, we were using horse serum for passive immunization, right? And when we were introducing horse serum for passive immunization of human being, let's suppose against diphtheria, right? So after injection of the horse serum, after a few days, patient will develop multisystemic inflammatory condition, which was called serum sickness. These days, serum sickness type reactions or type 3 hypersensitivity reactions are not most commonly due to foreign serum. These days, in modern era, such reactions are most commonly due to drugs. So it's worth writing that in the modern era, we are using foreign serum less frequently. So serum sickness type reactions are no more mostly due to foreign serum. These days, serum sickness like reactions or type 3 hypersensitivity generalized reactions are due to drugs, right? But we'll take as a prototype serum sickness disease and we'll talk about that, right? Let's talk about in detail the one example of serum sickness disease, how it can be induced and what are the pathological changes in body, how immune complexes are formed, how do they circulate, how they are deposited, how they produce the inflammation, what type of clinical presentation is formed in serum sickness, and then we'll talk about similar other conditions, right? So let's talk about serum sickness now. Let's suppose here is your circulatory system. Here is your circulatory system, right? And here we make your immune headquarters. This is your immune system. Immune headquarters, right? Here we make bone marrow house. Bone marrow house, right? Now we'll take an example that what really happens. Already you know that in the bone marrow what really happens that there are stem cells, right? And stem cell go into two lines, and from these lines there is erythroid line and there is there's myeloid line and there is lymphoid line. There is lymphoid lineage and myeloid lineage. Now out of this myeloid, right, one of the this myeloid lineage is responsible to produce RBCs, and it is responsible to produce myeloid lineage responsible to produce platelets, and this line is responsible to produce leukocytes other than leukocytes other than lymphocytes because lymphocytes are coming from lymphoid line, Now we have a story that this is a particular patient. First we are trying to understand the normal thing that this person has stem cells. Stem cells divide into lymphoid stem cells and myeloid lineage cells. Lymphoid stem cells will make lymphocytes and myeloid lineage will produce RBCs and platelets and leukocytes other than the lymphocytes. Am I clear to everyone? Now, let's suppose that here is your stem cell of the myeloid site. This is the stem cell of myeloid lineage. And this was the stem cell of lymphoid lineage. Is that right? Let's suppose this person unfortunately developed autoreactive T cells. He developed autoreactive T cells, lymphocytes. And unfortunately, these lymphocytes reacted against, what is this? Myeloid cell. In this particular patient, where we are taking an example of serum sickness, we are first making the foundation of a understanding that this person has developed a defect in immune headquarters, and immune system is making T cells, and these T cells are autoreactive T cells. And unfortunately, what these T cells have done? These T cells have reacted with the myeloid cells. This was the myeloid cell, myeloid stem cell, and these are autoreactive T cell, right? And this autoreactive T cell attacks the myeloid cells and destroys the myeloid cells. Now, if these myeloid cells are destroyed, number of RBCs will go up or down? Number of RBCs will go down. Number of platelets will be also going down. And number of leukocytes other than the lymphocytes will be also going down. So this person will develop three problems. Number one, he will develop anemia. Number two, he will develop thrombocytopenia. And number three, he will develop leukopenia. Is that right? But lymphocytes number may be number. Am I clear? Now, so you can say this person is having a disease in which his immune system is attacking inappropriately his myeloid stem cells and destroying the erythroid lineage and destroying the thrombocytic lineage and destroying the granulocyte monocyte lineage, right? So this patient develops severe anemia, right? This patient develops problems of anemia, right? With that, this patient develops thrombocytopenia. With that, this person develops penia. When someone has less RBCs, less platelets, and less white cells, we say this person has developed what type of problem? If all these three problems are there, yes. As a group, what is this problem called? Yes, please, you are all doctors. What is this condition called? Right. When there is thrombocytopenia, anemia, and leukopenia, when these three things are there, we call this condition, yes, please, pancytopenia. Pancytopenia. Have you heard of it? Pancytopenia. Now, bone marrow will be hypocellular, normocellular, or hypercellular in this condition. Of course, this person will be having all the features of anemia, pallor and fatigability with bleeding tendencies and with increased frequency and severity of infections. Is that right? So this patient in the peripheral circulation will show pancytopenia. Is that right? This person will show pancytopenia. But blood is showing deficiency of RBCs, WBCs and platelet. But when you do bone marrow picture, what you find in the bone marrow picture? Yes, please. What you find in the bone marrow? bone marrow will be hypercellular, normocellular or hypocellular. Of course, bone marrow cells are being destroyed. Bone marrow cells are being destroyed. As bone marrow cells are being destroyed, so bone marrow is hypocellular. So due to this immune attack, autoimmune attack on the myeloid stem cell, patient develop hypocellular bone marrow or hypoplastic bone marrow. Hypocellular bone marrow, or other term which is used as hypoplastic bone marrow. And with the hypoplastic bone marrow, patient develop pancytopenia. So hypoplastic bone marrow with pancytopenia is which disease? You know it. Hypoplastic bone marrow with pancytopenia, what is the name of the disease? You know it. When I will tell you, you will say you know it. I'm very sure you know it. You don't want to share your knowledge with me. Yes. You know that disease. I can bet you know it. Have you ever heard of, yes Rahul, have you ever heard of aplastic anemia? This is aplastic anemia. Aplastic anemia is a misnomer. You know, it is not only anemia, it is thrombocytopenia plus leukopenia. It is a misnomer. It should be ideally called aplastic pancytopenia. But I don't know why its name is aplastic anemia. But why we call it aplastic anemia? Because bone marrow is aplastic and peripheral circulation is showing anemia. But actually not only anemia, peripheral circulation shows thrombocytopenia as well as leukopenia. Is that right? So this is a patient of aplastic anemia. What is this? This whole story is the patient of aplastic anemia. And patient with aplastic anemia has hypoplastic bone marrow or aplastic bone marrow with pancytopenia and the peripheral blood picture. Am I clear? Of course, it's life-threatening situation. Is that right? If RBCs become very less, patient become very weak, oxygen transferring capacity is reduced, platelets are very less, patient has a high tendency to bleed, and of course what really kills very frequently is very low neutrophil and other white blood cells, and patient cannot defend against infections, and patient develops bleeding tendencies and repeated infections and very high risk of death. Now how do we manage this patient? There are so many ways to manage. One of the way to manage is we give animal derived antibodies to the patient. Let me tell you how. Look here. Let's suppose here is your friend. Let's suppose this is a horse. My drawing is not that good about the horse. It's an innocent horse. Is that right? Now, if we take, look, if you take the cell, what is this cell? Autoreactive cell, T cell. So if we take T cell antigens, what we take? T cell antigen and inject to this innocent horse. What we have done? We have taken human T cells and removed the human T cell antigens, and human T cell antigens have been injected to the animal. Do you think for this animal, human T cell antigens are self or foreign? Foreign. So Rahul knows it. So immune system of this animal, when it will receive these antigens, it will make the antibodies. What it will do? It will make the what? Antibodies. Now these antibodies, when we bring from animal out, these antibodies are derived from animal, from the horse, and these antibodies are against the human T cells, and we injected the animal with the T cell antigens, and animal provided us with the antibodies against the T cells. These antibodies are called, yes, what they are called? ATGs. ATGs mean what? Anti-thymocyte globulins, anti-T cell globulins. These antibodies are anti-T cell globulins. Is that right? Now, we give injection of this ATGs, to this patient, to our patient. We introduce ATGs, right? What are ATGs? These are special antibodies which are horse derived antibodies, is that right? And these antibodies are directed against human T cell. I hope up to now the story is clear. Now, these antibodies are given as treatment modality. These antibodies are given as treatment modality, and we expect that these antibodies should attack these T cells. They should attack these T cells. And if these antibodies attack these T cells and destroy these T cells, it means that destruction of myeloid cell has been reduced. Is that right? Attack on the, again, from the animal you derived ATGs. In some books it will be written ALG, but don't mind it. ALG also stands for anti-lymphocytic globulins. But because they are not against the B lymphocyte, they are specifically against the T lymphocytes. So more appropriate word is ATGs. So when animal is providing us with the ATGs, we inject the ATGs to this patient, right? These anti-thymocyte globulins or ATGs attack the T cells of the patient of the aplastic anemia. And when in aplastic anemia T cells are destroyed, naturally immune attack on the bone marrow is reduced, right? Because when immune attack on the bone marrow is reduced, what will be the result? When immune attack on the bone marrow is reduced, that these cells will again start proliferating. The cells which were still alive, right, they will start proliferating, and patients' RBC count will start going up, platelet count will start going up, and leukocytes start going up. Is that right? We say bone marrow will also start recovering and peripheral blood picture will also start recovering. Now, you must be thinking, where is our serum sickness? We did not talk about that thing yet. Okay, that is going to start very soon. Listen. Up to now, patient did not have any problem. You injected the horse antibodies to the person. These antibodies were ATGs, and these ATGs reacted with the human T cells, destroyed some of the human T cells. So autoimmune attack on the bone marrow was reduced. So bone marrow cells started proliferating. Bone marrow picture start improving, and you can say bone marrow start becoming more cellular, and of course end product of bone marrow activity will increase in the blood. So patient has increasing RBCs, WBCs and platelet count. So we say peripheral blood picture also start improving. Up to now everything is okay. But what happens? After a few days of injection of this horse serum, or after a few days of injection of ATGs, some of these patients who are injected with ATGs, they develop a special type of illness. They develop again fever, they develop generalized lymphadenopathy, they develop proteinuria and hematuria, they develop rashes, they develop polyarthritis, they develop pericardial pain or pleuritic pain, is that right? And multiple vasculitic lesions, right? And this whole complex is called serum sickness or type 3 hypersensitivity reaction. Now question is this, that how ATGs triggered the serum sickness like disease? What ATG did in the patient body that he developed such a special type of illness? Let me answer it. Actually, these ATGs or horse antibodies are taken up by, what is this? Immune headquarters. And our immune system, human immune system, will consider these antibodies as self or foreign. Our immune system will take these antibodies as foreign. So what happened? Even though these antibodies are good for us, that they are destroying our T cells and protecting us from the autoimmune disease, but unfortunately these are taken up by the immune headquarters. And in the immune headquarters, ATGs appear as antigen. ATG which are coming from the horse, even though these are antibodies against our T cells, but these horse derived antibodies are recognized by our immune system as foreign proteins. So these ATGs will be taken up by the antigen presenting cells, an antigen presenting cell will take up these foreign proteins and present them to the T helper cells, and you know that T helper cell will act on the B cells and convert them into, yes, plasma cell. And these plasma cells will start making another class of antibodies, and these black antibodies are the antibodies which are against the ATGs. These black antibodies are produced by the immune system when horse antibodies trigger the immune system. Is that right? An immune system take the horse derived antibodies, or immune system take the ATGs as foreign proteins. An immune system will make antibodies, human antibodies directed against the horse antibodies. How their horse antibodies will be processed, taken up by, processed and presented by the antigen presenting cells to the T helper cells. And T helper cells will activate the B cells into plasma cells, and these plasma cells will make anti-ATG antibodies. So eventually this patient will develop what thing there? He will develop, yes, anti-ATGs. That is, am I clear up to now? Now look, ATGs are now behaving as antigens and anti-ATGs are behaving as antibodies. Is that right? Now, if still in circulation, now what will happen? ATGs and anti-ATGs will react with each other, right? And when, so let's suppose this is the, what is this? ATG, and what is this reacting to ATG? Anti-ATG. Is that right? Now this is becoming an immune complex. So there will be a lot of immune complex formation within the circulatory system. Now these immune complexes will be formed within circulatory system as ATGs will react. You can say ATGs will react with the horse antibodies. Now these immune complexes are there. Now just formation of immune complexes is not enough to produce the disease, because in a normal person, if larger immune complexes are formed, immune complexes with larger size are formed, these are very efficiently removed from circulation by mononuclear phagocytic system. What are these? Mononuclear phagocytic system. Of course, monocyte derived different macrophages or Kupffer cells, or right, all those cells. Now this is the duty of, what is the duty of this? This is the duty of these macrophages, that these mononuclear phagocytic system should eat up all these, what is this, immune complexes. This is a normal phenomenon. Normally in human body, antigen antibody complexes do form, and these antigen antibody complexes are normally very efficiently removed by mononuclear phagocytic system. So they do not circulate unduly and they don't deposit here and there unduly. Rather, it is one of the normal pathway of elimination of antigens out of our body, that antibodies should react with the antigen, make the complexes, and these complexes should be eliminated by phagocytic process of mononuclear phagocytic system. Now, sometimes what happens, if in this particular patient, either immune complexes are very small, because this mononuclear phagocytic system is very efficient in phagocytosis of larger complexes. But if patient is making small you can say small immune complexes, then they cannot be efficiently removed. Or efficient remover may be impaired because there are so many immune complexes that this clearance mechanism is overwhelmed, right? Or someone has intrinsic defect in his mononuclear phagocytic system. So any one of these conditions, either complexes are very small complexes tend to circulate more and they less avidly bind with the clearance cells, or these cells are overwhelmed by the immune complexes, or they are having some intrinsic defect. Any one of these things will lead to impaired clearance of immune complexes from circulation. And immune complexes will circulate in our systemic circulation for shorter time or longer time. They will circulate now longer time. And if they are circulating for longer time, then they will start depositing in multiple areas. Depending upon, they will start depositing in multiple areas in the body if they are not efficiently removed. Now, in which tissues they will deposit, it depends on hemodynamic characteristics of that tissue. It depends on that what are the charges or lattice size or valency or affinity of these complexes. But anyway, let's suppose that this immune complex, this was the, you can say this was the antigen and this was the anti-ATG. Now this is the immune complex. This is the ATG and this is anti-ATG. This is derived from horse and this is derived from human immune system. And now they are making complexes within the circulation and they have not been efficiently removed. What will happen to them? Now they may deposit, right, in some part of the vascular system, right? They may deposit into some part of the vascular system. Let me show you that to which part they are depositing. I will show you there are some certain areas where circulating immune complexes love to deposit. Now this is the immune complex, right, which could not be removed. Now this immune complex which could not be removed, let's suppose it binds here with the endothelium, and when this immune complex, this has an active Fc portion. If some neutrophil or macrophage or mast cell is irritated by this immune complex, these cells may produce vasoactive, they may produce vasogenic substances. Again, let me tell you what really happens. In this patient, immune complexes were formed, right? Formation of immune complex occur around 10th day, right? 7 to 10 days after the injection of ATG, because 7 to 10 days are required by the immune system to capture, process and present the ATGs to the T helper cell, and T helper cell take time to activate the B cell to convert into plasma cell. So 7 to 10 days patient develop anti-ATGs and then immune complexes are formed. If immune complexes are not cleared efficiently, then what really happens that these immune complexes start depositing in multiple parts of circulation. For example, here this immune complex deposit, then active Fc portion of human antibody may activate some inflammatory cells, and those cells may produce vasogenic substances like histamine or other prostaglandins or like tumor necrotic factors, and these vasogenic substances will produce some vasodilatation, plus they will produce endothelial shrinkage and interendothelial gaps will be formed. What will happen? Interendothelial gaps will be formed. If interendothelial gaps are formed, it means that there is increased permeability of microcirculation wherever these complexes are depositing, right? Wherever these complexes are depositing, then what will happen? That these complexes may extravasate and they come into, yes, these complexes may come into deeper layers of vascular area. So these complexes may become, you can say, slightly embedded into wall of, they move from endothelial leakage site into the wall or media of the vessels. Am I clear? Now, we have seen how the complexes are formed and deposited. Again listen, phase 1 was complex formation. How immune complexes were formed? Antigen triggered the immune system made the antibodies, right? Antigen antibody complexes formed in circulation and they could not be cleared. This was phase 1. Phase 2 was these complexes start depositing into multiple parts in the body. I will discuss later which are the parts. Once they are deposited, the next phase is, the third phase is trigger of inflammation, initiation of inflammatory reaction.